And thank you, all of you, for joining us to this BRCCH webinar. It's a pleasure for us to have today here Professor Juan David Palacio. He is the main coordinator of the psychiatric unit for children and adolescents from the University of Antioquia in Colombia. And he has a master's degree from the University of London with a specialty on psychiatric diseases or disorders for children and adolescents. And he is the main coordinator of project research from the NIH. Today, he will share with us all his research interests and address all the various challenges, but also opportunities of research related to mental health in Colombia. So thank you very much for joining us. And as I said, Juan David, thank you very much. It's a pleasure having you.
Well, thank you. Hello, everyone. I'm Dr. Juan David Palacio, and I'm very glad to be here. First of all, I would like to thank Antia for the invitation and for the internship program. And I'm delighted to share with you what we have done in the group of research in psychiatry in Colombia. I'm going to divide the presentation in three parts. The first part will be explaining a little bit about the group, what we have done in mental illness. The second part is more towards explaining you the children and adolescent study that I have been conducting. And the third part could be something that we would like to develop with the time. I will start with the research group in psychiatry. It's a multidisciplinary group that has been conducting research for the last 3 decades. We focus mainly in severe mental illness. Of course, we have a study before other kind of illness, like ADHD, for example, attention deficit hyperactivity disorder, conduct disorder, PTSD, and other. But for the last years, we have focused mainly in severe mental illness, that is bipolar disorder, schizophrenia, and major depressive disorder. We covered both populations, childs and adults as well, and we have been rated in the top of the categories by the Minister of Health and Science in Colombia. We live here in this region. It's a very mountainous region. It's very difficult to move from one place to another. And for many years in the past, it was a geographical isolation. We live in this paisa population. The word paisa is derived from paisano, and this is a very distinctive population. It's a subcultural group in Colombia that shares not only this condition of geographical barriers by the mountains, but also dialect, religiosity, extended families, gastronomy, and other kind of traditions. This has made that this region, the Paisa population region, becomes a major isolate in genetics. So there is like a certain kind of genetic distinctive in this Paisa region that has become more homogeneity than heterogeneity. So it becomes a focus of interest for many researchers in Alzheimer's and also in psychiatric fields, especially for the severe mental illness. I will talk a little bit about the PAISA project in a minute, but first let me tell you about what we have done in our research group. We started focusing mainly in bipolar disorders like 20 years ago. We started working also with the University of California, Los Angeles, the UCLA, with Nelson Kramer, and we developed some descriptions about the adults with bipolar disorders, mainly about psychopathology, neurocognition, neuroimaging, and also in genetics. Then we start looking at the relatives. When I came into the group, I start this line of research about the offsprings, children of these parents with bipolar disorders. For the last decade, the group has moved not only from bipolar disorders, but now it's also studying schizophrenia and major depressive disorders. The three of them made the severe mental illness. So we are focusing on this. And we have developed already the PAISA project, that is a 10,000 subject sample. Also the PUMAS and the mission origin that is currently being recruited with a population of 100,000 individuals. But I will mention mainly here the PAISA project and the PAISA Kit project. Why to study children? Well, it is very important because children from patients with bipolar, schizophrenia, or major depressive disorder has a high risk, 3 or 4 times higher the risk than controls to have the same illness as their parents. And also they have the risk of having other kind of severe mental illness, 2 times the risk. So this is an opportunity because it's a high-risk population. So we can look at the children from a very early age, trying to see what the changes are, the first changes, the early changes that probably will evolve through the years and become the disease of bipolar disorder or other kind of severe mental illness. For the last 20 years, I've been conducting some studies in bipolar disorder offsprings, that's children with a parent with bipolar offsprings. And we have been studying clinical characteristics, psychopathology, sleep, comorbidities, also neurocognition, and some studies about neuroimaging. We have the opportunity, of course, to follow up one group of these bipolar offsprings. And what we have found is that they have a higher risk, not only for bipolar disorder, but also for other kind of illnesses, mental illnesses, such as ADHD, conduct disorder, anxiety, substance use disorders, and so on. Going back to adult projects, my colleagues in the group has started this project that is called the PAISA project. It's mainly in adults participants, and they recruited 10,000 adults. 8,000 were considered as cases because they have a history, a clinical history or electronic health record stating that they have bipolar, schizophrenia, or depression. And they were compared to 2,000 of controls. They did the psychiatric assessment, neurocognitive assessment, and of course, there are some studies in the genetic field trying to establish the GWAS analysis. Something really important about many findings that they had is trying to look at the trajectories of this disease. If we look at the right corner, upper corner, we can see schizophrenia, bipolar disorder, and depression. And in the other corner, in the left, we can see that not all of them started with this disease. That is, the trajectory is not linear. In many cases, the trajectory becomes with a switch in diagnosis. They started, for example, with ADHD, with conduct disorder, PTSD, or anxiety. How do we know this? Because we look at the electronic health records of these participants. At the beginning, for example, when they were children or adolescents, they have this diagnosis, and there were a change in this. This will be very relevant for us because in my group, studying children and adolescents, we will look not only for severe mental illness, but also for other kind of disorders that probably will be the first presentation of these offsprings. Here comes the second part of my presentation is the current studies that we have been developing in children and adolescents. One of them is the PAISA Kids. This project is investigating the relationship between genetic risk and early markers of psychopathology and the longitudinal clinical outcomes in this cohort of 3,000 children, PAISA children as well. We collect them. Our assessment is between the ages of 6 and 15 years. We have 2 main groups here at the left. The adults from the PAISA project are invited by phone, and we are trying to establish if they have descendants, if they have brothers, sisters, or they have children, first-degree relatives or even second-degree relatives, trying to establish three groups. One is the SMI relatives, that is the high-risk group. The second one is the control offsprings, the low-risk group. And there is another group that is very interesting for me. That is children that have been attending to a mental health hospital that already have diagnosis in the electronic health records. Any kind of these diagnoses, such as ADHD, conduct disorder, intelligent disability, intellectual disability, autism disorder spectrum, depression, and so on. Because these, as I mentioned before, are a special interest diagnosis that probably will evolve to severe mental illness. We start recruiting these children, and in 3 years ago, in 2023, and so far we have recruited almost 2,000 kids. We can see in the left upper corner, we have already 150 control relatives, almost 600 SMI relatives, and this is a special group here. The children with electronic health record diagnosis is almost 1,200. As you can see here in purple, there are many kids with ADHD, in yellow conduct disorder, intellectual disability, as I mentioned before, and here at the right corner, we can see that there are many kids with depression. This will be a special group that probably for future studies will help us to understand many things I will mention in a couple of slides. What we do currently is to assess them. We invite the main caregiver, most of the time is the mother, and we ask them, the adult, about the family history, the personal background, also the children dimensional scales. And there is something really important that we are looking for is if these children have been exposed to adverse childhood experiences, that is called ACEs. We also have the clinical interview. We are using the Kitty SAS, is a semi-structural interview. We interview both the adult and the children or the adolescents. Of course, we have other two items here is we do the neurocognitive assessment and also the DNA saliva sample. Something important, coming back to the ACEs, the adverse childhood experiences, is that we find that these participants so far in the PAISA kids has been exposed to many adverse childhood experiences. If we see here in the right corner, we can see that only 9% of these children have no ACEs. The rest of them has a lot of ACEs. And we cross this line, the 30%, the red line is showing that there are like 6 columns that are higher in adverse childhood experience. I will mention very rapidly that these kids have been exposed to separation of the parents. They are living with someone with mental illness or substance use, or they are exposed to domestic violence, or they have been feeling unprotected and also exposed to bullying. This is really important for us because when we find out, it becomes really interesting for us, this group, the last group that is called the EHR group, because in blue, we have the mean number of ACEs. And this group has a lot of ACEs. The mean number is almost 4. It's pretty high. And also, they have many diagnoses. But what happens if we not only focus on that children, for example, that has ADHD, but we look at the sibling? We are not currently studying them. This could be like an idea for future studies because the siblings, coming back to the sibling, he or she is exposed to the same number of adversity probably. So, and these are children that probably hasn't gone yet to the mental health hospital. So it becomes really interesting if we can study these kind of children. At the same time, looking at all the PAISA kids exposed to adversities, we have here in the x-axis the number of adversities. When we have 2, for example, the number of any children with any psychiatric disorder is 60%. With 4 ACEs, is 80%, and so on. It's no wonder that if you have more adversities, probably you will have a higher chance to have a psychiatric diagnosis. But there is something interesting here in the column of the 4 ACEs. If we look in the other way, there is 20% of children in this study that in spite of 4 ACEs, they don't have any psychiatric disorder. That's something interesting. There must be something, could be the age or any other kind of factors that is protecting them to have any psychiatric disorder. So there is an interesting question here. And here's the last part of my presentation is, why do some children do well despite adversity and a violent environment? It's an important question for us that could lead us to future studies. One of the ideas that we have in the last couple of months is trying to develop this study that is called the BRAVE study. The BRAVE stands for Building Resilience and Addressing Vulnerable Experience in Children. We would like to know what is the impact of these early adverse experiences in the mental health of our children. The research question is, what are the protective factors that play a role in these children that are exposed to violence and different kind of ACEs that prevent them to present a mental disorder? That is, of course, the noticeable idea to have high-risk factors to become mentally ill or to develop any kind of psychopathology. Probably could be in the middle, have protective factors or moderating factors. So that's what we would like to know. We live in a very violent country, and Antioquia is one of the states that had been exposed to the armed conflict. There are many kinds of armed conflicts: forced displacement, homicides, forced disappearance, and we also have a higher number of domestic violence, not only between adults. If we see the upper right corner, there is the percentage of the domestic violence by the group of age. The higher groups are the children and adolescents. We also have in Antioquia higher rates of sexual violence reported. And also in Colombia, we have been in the rank of the 11th country among the highest rates of a school bullying. So there is a lot of environmental violence. So for this new proposal, I will go very quick on that. What we would like to do is to longitudinally evaluate the role of social determinant and protective factors such as resilience as modulator of the association between ACEs, violence, and the development of a mental disorder. Remember that we could study children which already have a diagnosis, and also the siblings, that is an important group. Resilience is not a static process or a static trait. It's more a dynamic. This is an example of one of the protective factors. It's very complex and it should be studied at different levels. So I will explain very quick a proposal that we have in mind is to define resilience locally, to study resilience at 3 levels: individual, family, and also community, and probably through a multi-level model, try to analyze what factors could be involved in the development of resilience. If we have enthusiasm, time, and of course money, we will continue doing other things like design intervention to promote resilience. Excuse me. So define resilience in local community will involve focus group. I go very quick on this last part. And we will involve people with lived experience. We are convinced that we need a definition that is local to Antioquia or Colombia, because we cannot copy other kind of definitions. Of course, we could have some factors in common, but we can start doing this work, defining resilience in local communities. For the individual level, we can approach some children that are attending to the mental health hospital that is called the OMO. We have the possibility to explore 20,000 of electronic health records. And also we can have another perspective, that is to see some children that are attending to SURA. SURA is a health provider entity. We have almost 2 million children that are attending to this entity, that they are attend for other kind of disorders, but not mentally necessary. So we can compare these two groups. For the individual phase or individual level, we can establish two groups: cases, that is to study siblings of children that already have a mental illness, that children that have been attended to the mental hospital. We will explore the siblings that share the same environmental genetic exposures, but do not present clinical symptoms. And also, we can compare them to the children that are attending to SURA, that probably has been exposed to some adversity, but they don't have any mental disorder yet. We will, at the same time, we'll select some sample, around 1,000 or 2,000 children, to try to do a deep evaluation, and probably to start following them from children, 8 to 12, until they become adolescents. The follow-up for 2 or 4 years would let us know what kind of factors are involved in this trajectory. These are very quick, some factors that we are proposing to evaluate. At the family level, we can compare both kind of families. Cases will be, in this time, families with children without any mental disorder, but that they are exposed to moderate or high adversity. And the controls, in this case, would be those families that has at least one children with a mental disorder with a similar level of adversity. Here, some of the factors that we are intending to explore. And at the community level, this is the idea, is trying to approach 3 communities with the same level of adversity. 3 neighbors that have the same adversities, for example, homicides, domestic violence, sexual abuse, that we have the rates there, and probably they have different prevalence of mental disorders. This could be done because the SURA, the health provider entity, they have a lot of children from Medellin and Antioquia. So we can map these kind of communities and try to approach what are the differences between these communities that could be led to the risk of having a mental disorder, or in the other case, to protect them to develop the mental disorder. The first part will be the multi-level model. This will be like a complex analysis, trying to find out those characteristics that are involved in the protective factors or the resilience. And finally, what we are intending to do is trying to breaking down the resilient concept into behaviors, then trying to do like a behavioral approach, trying to do this analysis of behavioral determinants to promote these behaviors. Lastly, with behavioral change technique, we can map some of these behavioral change and probably try to propose or design a protocol to promote resilience. This is more of the same, and I think I will stop here. I hope you have enjoyed the presentation, and we can have some time for questions. Mhm. Mm, Okay, I have a question here. It says, at the presentation started explaining that the population is relatively isolated and that there are some genetic correlation. Have the research compare results with children not so isolated geographically? Okay, it's a very interesting this question because what I would like to mention is that we live in this geographical isolated, but that is to explain that for many years the paisa population was living in those conditions. Nowadays we have the roads and the means to move around. But what happened like 100 years ago? We have these limitations. So the Paisa population was established and they were married the same people. We keep the same surnames. That's why we start having that characteristics of a genetic isolate. So that's to me why it's important that we live in a genetic isolate. We are not like a population. For example, sometimes people ask us if we are in the Paisa population, we are similar to the Amish. No, we are not. We are living in modern conditions, but the genetic component is really important. There are other components that, of course, are quite different from other subcultural parts from Colombia, that is from the Paisa. But it's important to clarify that part. Okay, let's see. Okay. Hmm. No, no more. There are no more questions.
I can ask you, while I'm sure that people have some more questions or are thinking at home. Um, can you elaborate a little bit more? What would be your expectations or what you can foresee as possible interventions at the resilient level? I mean, and also, I mean, I guess that based on previous interaction at the community level, uh, what could really work there? And it could be probably different to another type of populations.
Yeah, it's a very difficult. We have thought about that. What could be like some of the resilient factors? Um, we are like our feeling at this point is that we feel like the gender, especially or the sex, especially females, they have more resilience in the previous years, in the early years, that they don't show so many mental illness, for example, like behavioral disorders. So there must be something at this point that probably protect females from that. Of course, when we reach the adolescents, we have some propensity of the females to develop other kind of disorders. So that's one of the factors that we are thinking about. The other is that probably anxiety could be uh, considered by many researchers as a high risk for other development. But what we are guessing at this point is that probably anxiety could help some children that to avoid to become in the future very complicated cases of behavioral disorders.
Like
Yes.
early identification of anxiety could already somehow flag these children, and
Right.
they could get support.
That's right. There is also something that we are trying to understand in our population. Even though there are some separated parents, and worldwide, the literature points out that this is a very risk factor. What we have seen for the clinical approaches is that when we have separated parents, the mother become very close to the children, and not only the mother, but also other kind of relatives. So it seems like that kind of new dynamics in the family could develop a protective factor. So this is something that of course, we like to study deeply, but this is something that probably will have some sense. And what else? Have been studying very low socioeconomic level. The paisa kids is a pop sample that is being recruiting most of the children, probably 75% of the children are in the lowest level. So we know that that is also an important factor for mental illness. But what we have found at the same time is that they develop other kind of skills, some kind of a mindset, for example. We haven't measured this, but it seems that children from low socioeconomic, some of them have show us that they have a special mindset. It's like a kind of a protective factor. It's kind of difficult to explain that in this moment because, of course, we would like to operationalize the research and also try to have very founded conclusions. This is more like from my point of view that I work not only in research but also in the clinical field that we have been seeing that. But this is a very interesting question.
Thank you. Let's check questions.
I'm going to check. Let's say here, I can see it truly. This is not a question, just a comment. I truly hope this project can be adapted for children in Peru. Currently, there is a significant gap in research in my country, particularly regarding the role of caregivers in relation to this diagnosis. Okay. Yep. Which also says that this is even more critical when we consider the deep disparities between urban and rural settings and a specific need across our different regions. That's perfectly true. I think it's not only for Peru, but I guess it could happen in most of the Latin American countries that probably we have that gap, especially to attend people that is living in the rural areas. Even the people from the urban that lives in the city, they don't have access. All of them don't have access to mental health care. So it's a gap in all Latin America. Thank you for the question.
We can wait 1 minute or two, and if there are no more questions, we can close the webinar.
I would like to mention something else. I didn't prepare any slide on this, but just to mention something that we have previously an experience studying siblings. We this is a different study. We ended this study 3 years ago, and we were studying ADHD, kids with hyperactivity and attention deficit disorder. And we start looking at the siblings, what happened to the siblings. And in this study, we focus mainly in trios. That's the mother or the father. We study one children which already has ADHD, and we look at the siblings, what happened with them. Most of the siblings, they didn't attend previously to a mental care. What we found in the 223 trios that we studied, and it was already published, is that there is a lot of siblings. 1/3 of the siblings have as well ADHD. But the parents, most of the time, take to the clinical consultation one of the children because was more affected, but the other children probably has another presentation of ADHD or was very mild and they didn't attend. But there is like something like very salient that is very quiet, and probably at the future, this sibling could have some repercussions. The other third of these children, of these siblings, have other kind of mental disorder. So it was amazing because the same. The only children that they uh, keep in the mental consultation was the child with ADHD, but the other kid was at home and was having depression, anxiety, other kind of diagnosis, and the parent didn't know. And there was another third of the kids that didn't have anything. That is the resilient group, we say. And it's interesting because there are other authors working with siblings as well, and they find out in many other mental disorders, for example, autism spectrum disorder, ADHD as well, even intellectual disability, that the siblings is like something that parents doesn't catch up. So it's an important approach. So that's why we are thinking so hard in this group that I explained earlier, the EHR, the kids that are already in the mental health hospital, probably there are some siblings at home that could have something. So,
Very interesting.
okay.
So really important. Okay. I think there are no more questions, so I would like to thank you all for joining us. Just to remind you that Juan David will be in Basel until the end of February. So please, if you would like to discuss further about his research interest or your projects, feel free to send us an email at the contact account of BRCCH, and we will try to establish a meeting with him and thank you very much in advance from our side.
Thank you. Thank you for your interest.
Thank
Okay.
you. Bye.
Bye-bye.